Hello, my name's Robin Simpson and I'm one of the Junior Clinical Fellows in Orthopaedics at the Bristol Royal Hospital for Children. I'll be presenting a study we've carried out looking at the impact of capsulotomy on the rate of osteonecrosis amongst children undergoing a medial open reduction for DDH. The medial approach to the hip is a useful means of reduction in children with DDH that have failed Pavlik harness or presented late and provides an excellent cosmetic result. However, the medial approach has developed a bit of a bad reputation. Some authors report excess rates of avascular necrosis, particularly type 2, which is lateral growth arrest. There is a wide range of data for this from different centres. Some of the best data comes from a systematic review and retrospective study by Rick Gardner in Toronto, which shows a 32% rate of avascular necrosis with longer follow-up, mainly type 2. But he also found that this maps most closely to the abduction angle in cast. Our question was, is this increased risk of avascular necrosis with the medial approach because the vessels lie directly over the site of capsulotomy? There is some anecdotal evidence only of cutting these vessels and it not affecting avascular necrosis. As denoted by the blue arrow here, the anterior approach starts away from the vessels. However, as you can see here, the medial approach starts directly over them. This green arrow, however, shows how these vessels are avoided during a psoas tenotomy. We found that a substantial majority of children that failed close reduction under a general anaesthetic will reduce after psoas tenotomy and not require a capsulotomy. We therefore looked at cohorts of children undergoing a medial approach according to whether they had a capsulotomy or just adductor and psoas tenotomies. Our hypothesis was that psoas tenotomy only did not present a substantial risk of injury to the vessels over a standard closed reduction, and the risk would be substantially lower than with capsulotomy. Our primary outcome measure was avascular necrosis according to the Calamchi-McEwen classification. We also looked at the abduction angle in cast based on Rick Gardner's work. Our cohort consisted of 48 hips in 42 children. We had a mean follow-up time of 8 years and 8 months. As expected, the group that reduced by tenotomy only was slightly younger than those requiring a capsulotomy. Within our cohort, we saw that the rate of avascular necrosis was considerably higher in those undergoing a capsulotomy. And as expected, type 2 avascular necrosis predominated. The abduction angle did map to the avascular necrosis rate as predicted by Rick Gardner in the capsulotomy group, but not in those without capsulotomy. So, we found that psoas tenotomy alone for a hip that has failed closed reduction will be successful in achieving concentric hip reduction in a strong majority of cases, and we found that this does not carry an increased risk of avascular necrosis compared to a closed reduction. However, capsulotomy does substantially increase the risk of avascular necrosis, particularly type 2, and sometimes after a period of delay. And so we avoid this during a medial approach if at all possible. Thank you very much.